Good morning, and welcome to today's webinar, Clinical Requirements and Best Practices for Title X Providers. My name is Brandy Johns, and I'm the Training and Development Manager at Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to community health centers and partners to improve access to health care for all, especially for underserved and uninsured populations. For more information, you can visit us at mvpca.org. Before we get started, I'd like to go over a few housekeeping items. During the presentation, please make sure to mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we'll hear your hold music. You will have the opportunity to submit your questions to today's presenter by typing your questions into the chat panel. You may send your questions at any time during the presentation. Questions will be collected and addressed throughout the presentation and at the Q&A session at the end of the speaker's presentation. Today's session will be recorded and slides will be available to participants. I would now like to introduce Jackie Witt, Clinical Professor and Director of National Clinical Training Center for Family Planning. Welcome, Jackie.
Thank you, Brandy. Let me bring my screen over here. Okay, I think we can get started. It's really nice to be with you all today. And I look forward to answering any questions or talking about any issues that we have, that you have. We have three main topic areas that we're going to address today. Looking at Title X guidance for providing male and adolescent services. We're going to look at what constitutes an encounter and what the required documentation for an encounter is. We're also going to look at the new rules, which are now in effect for about a month and a half, about adolescent services and pregnancy testing and counseling. Just a reminder that when we talk about clinical issues, we are primarily looking at the quality family planning guidelines that came out in the MMWR in 2014. However, there are underlying statutory requirements that affect clinical services. So we really draw from both in the clinical area, although a lot of the administrative requirements are going to be taken care of by someone else besides the clinical provider. Another reminder, when we talk about encounters and which patients count, so to speak, for Title X, we are looking at core family planning services. So the thing to remember is that the QFP says that family planning core services include avoiding pregnancy or achieving pregnancy, safe and effective contraceptive use, and protection of reproductive health. So that would involve HIV testing, STD testing and treatment, those kinds of things to ensure healthy pregnancy. So this is the diagram that has been around for a while now. Again, contraception, pregnancy testing and counseling, achieving pregnancy, infertility, preconception, and STDs. Most projects also include closely related preventive health services. They are services that are focused directly on reproductive health and pregnancy and protecting reproductive health, but they are not in the core. So for our purposes, most places, for instance, have cervical cytology, cancer screening included in their project. When you receive multiple funding streams, that's up to your project to decide if the Title X program is going to pay for those related preventive health services. In addition, there are other preventive health services that are not generally covered by Title X. In fact, it would be pretty large, atypical thing for a project to cover things like lipid screening and diabetic screening and that kind of thing. But it is required that all sites have referral sources for that. Not a big issue for your types of systems because you have primary care readily available within your health centers. Another reminder for you, as we look at family planning services, the quality family planning recommendations really apply to two types of encounters with people, women and men of reproductive age. In the first type of encounter, the primary reason for a client's visit to a healthcare provider is related to preventing or achieving pregnancy. For clients in this category, providers should assess whether the client needs other related services and offer them to the client. On the right side of the screen is the second type of encounter. The primary reason for a client's visit to a health center or a healthcare provider is not related to preventing or achieving pregnancy. So the client might come in for acute care, like a male client coming in for STD symptoms or as a contact of a person with an STD, or for chronic care, any other kind of preventive service. In that situation, providers not only should address the client's primary reason for the visit, but also assess the client's need for services related to preventing or achieving pregnancy. And that doesn't mean that that service has to be provided that day. This says, if needed, provide services. That does not mean it has to be same-day service, although it would be nice if you're able to pull that off and get them into family planning the same day. So one of the things that we get a lot of questions about is reporting, and I'm going to warn you that these slides are busy, and I'm not going to read them word for word, but I wanted you to have a reference right from the statute so that as a clinician or as an administrator, you are able to pull up the requirements when you need to, because we certainly can't cover every possible scenario for when you are able to count a client as a Title X patient. So the Family Planning Annual Report is the data source that we use for Title X monitoring. And this is really uniform reporting for Title X. It provides national level data on the program and really is helpful for dealing with legislation, dealing with other federal agencies, and for us to get feedback about who we're serving. More important to us, I think, and the thing that we get a lot of questions about is, what is an encounter? An encounter is synonymous with a clinical family planning visit. So it has to be documented, it has to be face-to-face. Recently, there has been guidance from OPA about telemedicine. The thing to remember about face-to-face contact and telehealth is that it has to be an approved part of your project. So you can't suddenly decide that you're going to start seeing patients by telehealth digital connection, but that is considered a face-to-face visit, and you can count those clients. So, it doesn't exactly match with what's on the screen, that the client might not be in a Title X setting, but you are, so you are able to count that. Again, the reminder here is the purpose of the visit is to provide family planning and related preventive health services to people who want to avoid unintended pregnancies or achieve intended pregnancies. A written record of these services provided during the family planning encounter has to be documented in the client record. The other thing I want to stress is that Title X is not insurance. Title X is, I like to call it kind of a service agreement. So your project gets so many dollars to do so many things. And so I get a lot of questions about, quote, double dipping. Can I report this? Can I, quote, submit a claim for insurance? Do I report it to UDS as well as Title X? Yes, 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 yes. Title X is not insurance. There really is not such a thing as double dipping with the Title X program. It's not a fee for service kind of thing. So I have questions throughout here. I just want you to take a minute to think about this. If the project also gets 330 funding, should family planning users be reported to OPA and to UDS? And as I said, the answer is definitely yes. Report all relevant data elements appropriate to FPAR and UDS. And if it falls in both buckets, then it does. Perfectly fine. This is one of the references that I wanted you all to see, but I'm not going to read it to you. This is here for your reading pleasure later. So a reminder as clinicians with our documentation, I think what happens sometimes is we don't take credit for everything that we do during a visit. So if you're seeing a client for diabetes, for instance, if you are also providing appropriate information about achieving or preventing pregnancy, you can absolutely document the interaction and classify them as a family planning user. So things like, how are you doing with your method? Would you like to become pregnant in the next year? Have you thought about your options for achieving or delaying your next pregnancy? Again, I think we sometimes just do not, if it's not an absolute pop-up in our EHR, sometimes we don't take credit for asking those questions and having those conversations. Another reference for you, everyone who is, quote, counted as a Title X patient, of course, must have a medical record, and the client medical record must contain enough information that we can find the client, indicate where and how the client can be contacted, justify the clinical impression or diagnosis, so it has to be coded correctly to count as a family planning encounter, and obviously our diagnosis always has to warrant the treatment and the results. Just a reminder about service sites. Family planning service site refers to an established unit where grantee or subrecipient agency staff provide Title X services. Again, has to be for pregnancy, prevention, or achieving pregnancy. Established places might be clinics, hospital outpatients, homeless shelters, detention and correction facilities. Amazingly enough, we've had questions recently about health fairs and those kind of things. If you have a face-to-face visit, you start a medical record and the client interacts with a family planning provider, then that can be counted also. Mentioned this briefly before. Again, reminder, has to be in your approved application, especially if it is a non-traditional site, like if you have a van or, again, telehealth. Let's look at some encounters because I think that helps solidify this in our minds as we take a look at actual things that I think are probably happening at your sites all the time. So the first one is the 25-year-old with type 2 diabetes. It's a female. She's planning a pregnancy. She's asked by the provider if she's planning a pregnancy in the next year. Patient says no, and so you would go ahead, and she's not on contraception, so the provider appropriately would ask if she wants to discuss birth control. The patient just says, no, not really, but I would like some condoms if you have some. So in order to provide appropriate documentation that the patient is not just using condoms to decrease the risk of STD, you want to have something in your conversation and your note that you discussed condoms as pregnancy prevention, and probably encourage her to think about other birth control methods and come back at a later time if she changes her mind and wants something more effective. And obviously more important for someone with a chronic disease. We probably would all do this anyway. It's just that I am emphasizing the documentation that has to be there. And here's your Z code for that. So next is a 31-year-old, and she just comes in for a pap smear. And while you're doing it, you see IUD strings. And so you ask, how long have you had the device? Are you happy with it? Does she have any questions? And she's had the IUD for 2 years. She's very happy and satisfied with it and has no problems since she got it. Again, as long as you document that you talked about those things and you document a code for either IUD surveillance or presence of IUD, then you can count that patient as an OPA or a family planning visit. Next is a 34-year-old. She has been having irregular menses. She's there for a pap smear today and requests a pregnancy test. We would do one anyway since she is at least a week late for her period, even though she states she has irregular periods. So this one really is it just depends. So if the client's returning or an ongoing family planning client and she obtains any core family planning or related preventive health service, she can be counted, regardless of whether she receives core family planning services on the same day. If this is the first visit, so if the client is not an ongoing family planning user and obtains a service that doesn't include counseling, education, or clinical services related to achieving intended pregnancy or avoiding unintended pregnancy, the encounter is not a family planning encounter and the client can't be counted as a user, a family planning user. So let's say another example would be a new client who receives FTD services, but no counseling, education, or clinical services aimed at avoiding an unintended pregnancy or achieving an intended pregnancy, is if she's not a family planning user and the encounter is not a family planning encounter. But if in addition to STD testing, this same client, like our previous one, gets counseling about using condoms to prevent STD transmission as well as preventing pregnancy, then we would count her. So what doesn't count as an encounter? Anything that does not meet the 3 criteria. Standalone lab tests like just a pregnancy test aren't included as encounters unless there's a face-to-face contact between the client and the provider. There's documentation by the provider in the record, and the test is accompanied by family planning, counseling, or education while she's there. So let's look at another scenario here. Joe and his friend Mary walk into your service site. Mary's in her 3rd trimester. While Joe's being seen, Mary decides to speak with a clinician. That would be amazing if a clinician was available, but Mary finds one. And she wants to learn about contraceptive options that would be safe for her if she breastfeeds. Could she be included in the FPAR as a Title X family planning client? Yes, absolutely. The 3 criteria are present as long as all of this is documented. Absolutely. She's seeing a provider. She's getting family planning advice. How about Martha, who walks in with a, this is the time thing and whether or not the patient is new or return family planning visit. So Martha walks into your FQ and she has symptoms of a UTI on January 12th of 2019, let's say. She was, or 18, I guess. She was screened and treated at that time just for the UTI. And on December 29th, she returns to the service site for chlamydia screening and a pregnancy test. She gets negative pregnancy test results and decides to begin receiving Depo-Provera injection, which would require a diagnosis and a provider prescription. So can we count her as a Title X family planning user? For the second visit, yes, because she is an ongoing patient for you and she is receiving family planning services in the same year that she started receiving services. I know this one is more obscure. I'd like to pause for a minute now, and we're moving into mail services. There are basically 4 sections to the webinar. So any questions about encounters? I would like us internally.
Phones are unmuted if you have any questions for Jackie.
Okay, let's talk about men then. In the quality family planning guidelines, there are pretty easy to follow diagrams for all of the services that need to be provided if a patient presents for any Title X service. So you can see for males that present for contraceptive services and STD services, as well as infertility services, there needs to be pregnancy intention question asked, and full medical history, as well as a sexual health assessment. Immunizations at least need to be discussed, and they can be provided if you have that capability on site. And usually the ones that we think of that are associated with sexual health are HPV and hepatitis B. You can see for preconception health services, again, we're trying to provide for safe pregnancy planning. There are a lot more questions and a lot more history that needs to be collected if you count this for a preconception visit. I should say that the most of the clinical guidelines are taken from 2 primary sources. One is USPSTF, and the other for females is ACOG. Those were the primary references and resources for these guidelines. So all patients presenting for services need to be asked about pregnancy planning. That might be one key question. It's sometimes dictated by what's already loaded into your EHR. The newer kind of shared decision-making model that is being promoted by OPA, and it's not a requirement. It's emphasized, but is not a requirement, so I don't want to get anybody nervous here. But it is attitude toward pregnancy. So do you think you might like to have children someday? Is your partner on contraception right now? Would you like to talk about that? And when might you all want to get pregnant? And then how important is it? How important is it to you to prevent pregnancy? Because research over the last 10 years has shown that although providers tend to think that effectiveness is the most important criterion for patients, a lot of times it's not. If it happens, it happens kind of attitude. So making sure that you understand where they are. Sexual health assessment, again, most EHRs have some kind of sexual history in them. What is promoted and what you will see in the QFP says to use the CDC STD treatment guidelines. Those are due out early 2020, and CDC says we might be seeing a change in gonorrhea treatment, obviously because of resistance, and Mycoplasma genitalium will be addressed. MGent is what it's called. Yeah, I'm sure you've heard it's an emerging STD. There's only one commercial test available for it, and it's made by Hologic. So anyway, stay tuned. More about STDs and STD treatment very soon. So again, when appropriate, providers should discuss information about female-controlled methods, including EC. Talk about men as partners in pregnancy and in reproductive health, and also talk about condoms if the male prefers to have male-controlled methods available. Basic infertility services are included in Title X projects. When the new QFP came out in 2014, there was a lot of angst about this. Actually, this has been around since the first guidelines came out. There's just renewed interest or renewed emphasis by OPA on male infertility services. And your project can pay for semen analysis for males. So we do a basic infertility workup, not anything like what reproductive endocrine people would do. Very, very basic, but semen analysis can be included. Unlike females, we can't do any testing related to infertility for females. No hormone tests, none of that. That is not included in projects and would not be approved if you put that in your project. Preconception health services should be offered to all clients, as I've mentioned. I just want to emphasize that if you're counting a male as a Title X client, talking about preconception health services is good documentation. QFP says that, again, we should treat males as partners in the pregnancy planning process, and moreover, that these services are really important, especially for indigent men, for improving their health regardless of their parenting intentions. I think this was on the diagram that I showed you, again, just for your reference here. Medical history, of course, for preconception should include questions about reproductive health and anything that might impair his reproductive health, like genetic conditions, history of previous reproductive failure, conditions that can cause reduction in sperm quality, such as obesity or diabetes, varicocele on exam, and environmental exposures, toxins like smoking and alcohol and other substance use. STD services for men, I think, are pretty straightforward. I'm not going to spend a lot of time on this. The QFP clearly directs us back to CDC STD screening and treatment guidelines for all STD services. Again, for your reference, nothing new here. This is surprising to some people since we have gotten away from doing routine screening pelvic exams for females. The reference for this is actually Bright Futures, so the pediatric reference. QFP says that for adolescent men or adolescent males, exam of the genitals should be conducted. This includes documentation of normal growth and development, hair distribution, et cetera, and other common genital findings, including hydrocele, varicocele, and signs of STDs. Components include, again, inspecting skin and hair, palpating the inguinal nodes, scrotal contents, and penis, and inspecting the perianal region as indicated by the history. So by statute and quality family planning guidelines, confidential family planning services are stressed, and they should be available without discrimination, and that includes age discrimination. But the caveat here is this is a state-by-state thing, so there are not any overarching federal Title X guidelines that would supersede your state law. So any legal obligations that you have for mandatory reporting of child abuse, sexual abuse, human trafficking, et cetera, would be taken care of on a local level. Absolute confidentiality is critical for many adolescents and really can influence whether they not want to receive care from a Title X site, any site, but from a Title X site. So I think there's not a lot new in providing information to adolescents. Absolutely, QFP says providers need to give comprehensive, complete information to adolescent clients in a way that they can understand it. I think that what is a little bit new is increased emphasis on the top factor here, abstinence and sexual risk avoidance. So Office of Population Affairs is really working with us to operationalize that term. And the guidance that we have received so far is that it really requires a, quote, meaningful conversation with adolescents about whether abstinence might be an option for them. So something like, so we've talked about everything from abstinence to IUDs. Is there, and obviously abstinence is the safest and most effective way to prevent pregnancy and STDs. Do you think that might be an option for you right now? So something like that, instead of only monitoring for sexual coercion or sexual abuse. And I think many of us do it. It's age-related sometimes. I will tell you that I'm more likely to do that with my younger adolescents than I am with my older adolescents. But again, it's one of those things that I really think we do it. We just don't document that we've had the discussion. There's also renewed emphasis on documenting that you have talked about parent-child communication. Family involvement has always been a principle laid out in the Title X recommendations and in the statute. Adolescents who come to the service side alone should be encouraged to talk to their parents or guardians. Educational materials should be provided to parents or guardians that help them talk about sex with their children. And joint discussions, if the child agrees, can be very helpful in some instances. I've had a recent question about a child in foster care brought in by the foster parent, but they don't have legal guardianship yet. What do? You can't do anything. You encourage them to talk to a trusted adult, and it's not a parent, but it is a trusted adult. And sometimes it's just not possible. So some new rules for Title X here. In the area of adolescent services, the new regulation that took effect in August says that grantees and subrecipients are required to provide annual training, documentation, and written protocols for their project about state requirements for notification and reporting of child abuse, child molestation, etc. This requires education and counseling for minors on how to resist sexual coercion with documentation that was provided. We just haven't had explicit guidance like this before. I think it was implied with the phrase parent-child communication and following state laws on mandatory reporting, but it wasn't spelled out like this for us. Again, documentation of encouragement of family participation in family planning decisions, as well as documentation that it was done or reasons why it was not done, like the child is in a detention facility or in foster care or whatever, and it's not appropriate or it's not possible. So we're moving into a section on pregnancy tests right now. I'd like to again ask if anyone has any questions. Happy to answer before we move into pregnancy tests, but we can also answer questions at the end.
Jackie, we do have a question asking if we can clarify that HPV vaccination is covered for men.
Yes. If it's in your project, you have to have an approved project. So if there are other funding sources for HPV vaccine, like vaccines for children, or even 340B pricing, then probably you're going to spend your scarce Title X dollars on family planning, which is the emphasis. But yes, it can be a covered service, but I don't know what your approved project says. Anything else? Okay, let's move into pregnancy testing and the new rules. We're about at the end here. And I know I'm talking fast. I hope that if you do have any questions or clarification later even, please email me. My contact information is on the cover slide for the presentation. So just a reminder that routine pregnancy testing or standard pregnancy testing is not recommended by CDC's selected practice recommendations for contraception. If a woman meets one of these criteria and therefore the healthcare provider can be reasonably certain that she's not pregnant, a urine pregnancy test might be considered in addition to these criteria based on clinical judgment, bearing in mind the limitations of the accuracy of pregnancy testing. For instance, if a woman doesn't meet some of the timing criteria, then the healthcare provider can't be reasonably certain that she's not pregnant, even with a negative pregnancy test. And so that's why the emphasis on routine or standard pregnancy testing for every woman is not the norm. On the basis of clinical judgment, also, healthcare providers might consider the addition of a urine pregnancy test. However, they should be aware, again, of the limitations, including accuracy of the test relative to the time of the last sexual intercourse, recent delivery, spontaneous or induced abortion, which is recent, and routine pregnancy testing for every woman is just not necessary. If a woman has had recent, for instance, within the last 5 days, unprotected sexual intercourse, consider offering emergency contraception in that instance. Remember, the most effective emergency contraception is the copper IUD, but certainly we have oral medications available. And just a reminder, ulipristal or Ella is better for many reasons. FDA approved for 5 days instead of 3, more effective, works with increased follicular diameter, so is better at preventing unwanted pregnancy. And remember that they're not considered abortifacients, so no problem with your Title X project, only work before ovulation. So pregnancy testing and counseling should include discussion of, whether this is good news or not, what is the pregnancy intention, medical history, pregnancy test again, if appropriate, and confirmation of the result with the client. So here are our new rules for pregnancy testing, and I'm going to tell you that we are not daily, but still very frequently receiving additional detailed guidance from OPA on this rule. So I have given you the summary version here with the reference and the website where you can read the whole rule, which is long and boring. I think this has boiled it down pretty well, and this is directly from the OPA website. Referral for abortion under the new rule, and they always say referral for abortion as a family planning method is prohibited. Referral for abortion is permitted for medical emergencies, so an inevitable miscarriage, an inevitable SAB, or that kind of thing. They even use the example of an ectopic. Well, of course, all of us would refer for an ectopic. Or in the case of rape or incest. In the old regulation, referral for abortion was required for every client who requested it. In the new rule, non-directive counseling on abortion can be done, but it is not required. And this counseling has to be done by an advanced practice clinician or a physician. So the example here is your medical assistant can run the pregnancy test and can, obviously give the results. Your pregnancy test is positive today, and can list the legal options. So would you be interested in prenatal care, abortion, or adoption? Or those are the available choices that you can choose. If the client says, I want more information on prenatal care, your MA can do that. If your patient says she wants more information on adoption, your MA can do that. If your patient says she wants more information on termination, she has to see a provider. And it's not required that she see a provider that day, but she has to be directed to a provider. The MA cannot discuss abortion. All positive pregnancy test results require referral for medically necessary prenatal care to promote optimal health. So what this boils down to on a day-to-day basis is we can not refer patients directly for abortion, and that includes advanced practice nurses, PAs, and physicians. We are able to give a resource list, which includes providers who care for women after a positive pregnancy test. That includes providers that provide prenatal care, maybe social service agencies that provide adoption planning, and providers that provide abortion services. We may not point out, circle, or group a referral by the services they provide. So you can hand someone an alphabetical list of providers in your community or within your setting. You all have multi-specialty and multi-services in many of your settings, but you cannot direct the patient towards anyone that specifically does abortion. You can, however, direct them to prenatal care. This is sticky, and it's new for a lot of providers. Happy to answer any questions, and if I don't know the answer, I'm going to direct you back to your project officer. As I said, we are almost receiving daily guidance on how to handle the new rule.
Jackie, we do have a question. We have asked, can you give us an example of what we might say if a client asked us for an abortion referral and did not have a medical emergency or rape?
Yes, let me think about that for just a minute. I don't have a script in my head. Give me 10 seconds here. So the medical assistant is telling me that you're interested in an abortion referral since you've had a positive pregnancy test. We don't care for women here after they have a positive pregnancy test. This is a family planning site. So I'm going to give you some referrals that provide care to women after a positive pregnancy test. Some of these provide prenatal care, some of them provide abortion, and some of them provide adoption services. And here's our list in alphabetical order. That's the best I can do, guys.
Thank you. Also, they asked, a health educator can't discuss abortion rights, abortion either, right?
Correct. Correct. That is correct. It is, I will tell you that the current Deputy Assistant Secretary for Population Affairs was not on board when the previous political appointees wrote the rule. And she has had multiple conversations with us about sort of how to get around some of this. Like if somebody has the physician in the office might not be the best person to talk to the client about a positive pregnancy test, but it is so clear if you go to the statute. I mean, it even spells it out that it must be an advanced practice register. Oh, and you have to have a graduate training. It says very, very, very clearly, no one else at this time can do that counseling.
Well, maybe she can't. She asked, okay, so if there's a provider that exclusively provides abortion, can we still put them on the referral list? And what if the clinic has the name abortion in their title?
You know, I haven't been asked that yet. I think that would be okay if it's within the list. But you know what? I'm going to get back to you on that. Do you know where this person is? Well, I can just get it back to you, Brandy and Alicia. Well, let's get that out to people because I have not been asked that yet. I don't want to misspeak for anybody.
Perfect. We can share that information.
Sure. Like I say, this is sort of late breaking news for us too, you guys, and I'm the messenger. Remember, lots of good information on the OPA website about the new rule. Obviously, I gave you excerpts. There are other administrative kinds of things in the new rule, but I thought primarily clinical audience would be interested in the excerpts that I presented. And if you don't have any questions right now, we are always here. I really will welcome any questions, any comments, and we are not the police for the Office of Population Affairs. So we are a training center. We are committed to helping you provide services. So if you have a question, just ask. Or go through Alicia if you want to be anonymous. That's fine too. She can ask me. The other thing that I can do is to keep you anonymous. If you have a question, I can ask the question, quote, from the field. So if you have a question about something, processes in regard to the new rule that you're not sure about, you can certainly ask us. We can ask OPA and get back to you. Brandy, thank you for structuring this for us. And I really look forward to talking to you all later.
Thank you. And thank you, Jackie, and thank you to everyone for attending. We'll be sending out an evaluation after this session. We appreciate your feedback. If you had more than one person in your room, if you could please send me at bjohns@nvpca.org the list of names and email addresses so that we can make sure you get your credit for it. That would be great. And on behalf of Nevada Primary Care Association and the National Clinical Training Center for Family Planning, we thank you for joining us and have a great rest of your day.
Thank you all. It was great.